who has a joint MD PhD degree in pharmacology. He is currently a clinical cardiologist at Emory University. Do you have your slides on? Yeah. Okay.
Hello everyone, so I'm Bruno Lima, so I'm gonna present a study on PTSD associated with enhanced interleukin-6 response to mental stress in subjects with a recent myocardial infarction. I have no disclosures. First, PTSD is a really common disease with a lifetime prevalence of about 7 to 8% in civilians and about 20% in military veterans. It is associated with greater than 50% increased risk for incident cardiac events and mortality. But not only that, since a life-threatening cardiovascular disease event can itself result in PTSD with further increased risk for subsequent adverse outcomes. There are several potential mechanisms mediating this interaction. For instance, individuals with PTSD, they have increased activation in the HPA axis as well as the sympathetic nervous system. And also, PTSD patients, they are more likely to engage in poor health behaviors like smoking, substance abuse, and all of these factors, they work in conjunction to increase heart rate, increase blood pressure, cause platelet dysfunction, as well as increase inflammation. That seems to be a major factor mediating this association. The relationship between PTSD and inflammation is pretty well established in the literature. There was a meta-analysis from Lancet Psychiatry from 2015 that showed that patients with PTSD had a higher baseline IL-6 levels as well IL-1 beta and TNF-alpha. However, the mechanisms linking PTSD and inflammation are not yet established yet. However, some prior work showed that PTSD patients have more methylated genes related to inflammatory function compared to healthy controls, which could lead to the expression of enhanced inflammatory activity. Also, PTSD patients are more propense to psychological stress that upregulates pro-inflammatory gene expression via stimulation of beta-adrenergic receptors in immune cells, and also chronic stress via overactivation of the HPA axis over time that regulates glucocorticoid receptors that eventually lead to higher inflammation. However, there are several gaps in the literature since almost all of these studies of PTSD and inflammation are cross-sectional. Also, no prior studies evaluated inflammatory response to mental stress in PTSD. And finally, no studies evaluated biomarkers, some of the biomarkers relevant to cardiovascular disease. So, we aimed in a sample of young post-MI women and men to answer the following questions. Do patients with PTSD display an enhanced inflammatory reaction to mental stress compared to non-PTSD controls? And our main biomarker of interest was interleukin-6, which is known to be responsive to acute stress, thanks to Dr. Marsland meta-analysis from last year. And all the biomarkers related to cardiovascular disease risk that we evaluated were high sensitivity C-reactive protein, matrix metalloproteinase, also known as MMP9, monocyte chemoattractive protein, or MCP1, intercellular adhesion molecule, or ICAM1, and vascular cell adhesion molecule, or VCAM1. Our study population consisted of individuals from the myocardial infarction and mental stress ischemia study, or also known as MIMS-2 study, which enrolled 271 patients within the MI within the past 8 months. And it was broken down by 132 women and 137 men with ages below 61 with a mean of 50. And all patients underwent mental stress testing. So the mental stress protocol started with patients who were tested using a standardized public speaking task after a 30-minute rest period in a temperature-controlled, quiet, and dimly lit room So briefly, the patients were asked to imagine a situation in which a close relative had been mistreated in a nursing home. And the patients were given 2 minutes to prepare and 3 minutes to deliver speech in front of a video camera and with an audience wearing white coats as depicted here. Other study measures, so we diagnosed current PTSD, meaning within the past 2 months, within the past month, using SCID for DSM-4, and we had a total of 32 patients with PTSD. And we measured plasma inflammatory biomarkers at rest and 90 minutes after mental stress. Some other measurements, for instance, lifestyle factors like smoking, medical history, including diabetes and hypertension, some cardiovascular heart disease risk factors, some behavioral and social assessments like depressive symptoms using back depression inventory, and general stress using Cohen's PSS scale. For statistical analysis, we use linear mixed models for repeated measures, adjusting for demographics, cardiovascular risk factors, and depressive symptoms, as well as plate effect as a random factor. So regarding our study population, well, at least in our sample, we show that patients with PTSD were more likely to be African American, had a lifetime history of major depression, have more depressive symptoms, and have more stress symptoms at baseline. However, whenever taking a look at the clinical characteristics, like for things like diabetes and dyslipidemia, heart failure, there's no significant differences between our PTSD population and our non-PTSD population. So we found that PTSD patients display an enhanced interleukin-6 response to mental stress compared to non-PTSD patients. For non-PTSD patients, we saw a 63% increase in IL-6 from post-stress to rest, while PTSD patients had almost double of that, with 126% increase. And those results were similar even after adjusting for some demographic and cardiovascular risk factors. We also assessed all the inflammatory biomarkers. However, we didn't see other differences based on PTSD status, either in baseline levels or in response to stress. However, we saw that all markers significantly increased with stress, except C-reactive protein and ICANN. And also we found that ICANN1 resting levels were high in patients with PTSD. Our study had several strengths since it was done in a large, well-characterized sample of young post-traumatic patients using an experimental manipulation. We're assessing a comprehensive panel of biomarkers in a racially diverse sample with large proportion of women. But we had some limitations since we lacked some clinical outcome data, and also it is unclear what's the prognostic significance of increase in inflammatory biomarkers after mental stress, although we are working on this. And the other limitation is that we chose the post-stress sample of 90 minutes, which is adequate for biomarkers like IL-6, TNF-alpha, and IL-1 beta, as demonstrated before in the literature. However, for other biomarkers like CRP, it might not be the optimal time. So that's another limitation. And the thing is, we only assess patients with myocardial infarction, so these results are not necessarily generable to other populations. And final remarks, we found that PTSD was associated with an enhanced IL-6 response to acute mental stress in young middle-aged patients with MI. PTSD was not associated with enhanced response of other biomarkers. And this increase in IL-6 response to stress may play an important role in the association between PTSD and cardiovascular disease, but this is something that needs further investigation, especially now that last year we had the CANTOS trial in which we are treating cardiovascular disease patients with anti-inflammatory medicine. And that trial showed that there is some mortality benefit. So maybe identifying populations like depressive patients with PTSD patients who might benefit further, from those kinds of therapies. I mean, might be the future direction of those of that kind of research. And I'd like to acknowledge, my mentors. Some of them are here: Dr. Viola Vaccarino, Dr. Bremner, Dr. Kayumi is not here, Dr. Shah, and also the other cardiology fellows and postdocs that work in this project. And that's it. Thank you very much.
There's plenty of time for questions, so.
Yeah.
It was a great presentation. I was curious if you could comment, and maybe I missed the metrics. Was the MI the actual criteria event for the PTSD? And if not, what were some of the criteria events that were identified?
Yeah. So the MI was not the criteria of PTSD. Actually, most of these patients, they had PTSD before they had an MI. About it's within the range of 80 to 90% of patients actually had PTSD before the cardiovascular event.
Looking at your results in terms of the absolute levels of the cytokines and so on, it looks extremely low. Number one, were you able to use a high sensitivity ELISA for that? And number two, did you have a lot of people whose levels were actually below detectability with your assay?
So these are two really technical questions. However, in terms of detection, what I can tell you is that there were not actually many patients with levels below the level of detectability.
Within the standard curve?
Exactly.
Okay.
Yes. Yeah. I didn't see many patients with that. Regarding the other question, stating that these were kind of lower levels. Actually,
Picogram levels.
Yes. I have no. This question. I actually didn't compare, with other, studies, to see how does it compare, with other, studies. Yeah, but that's an interesting, consideration. I'm gonna definitely, take a look, further at that. But it's a great observation.
Just wondering, did any of the MI patients differ, in terms of treatment? Like if it was a silent MI versus a cath lab and they had a stent placement, was there any clinical differences within the MI population?
Yeah. So basically, we divided. Well, all of these patients they had an MI, within the past 8 months. So all of them they had CATs within the last 8 months. So we control for differences we use Gensini scores, which is basically a measure of plaque burden in these people, and also we also compare. I don't have it here, but we compare the type of MI that these patients had. But there's also no differences between the PTSD and non-PTSD population, and also comparing the Summit REST score, which is basically it's kind of a stress test, like a nuclear stress test, taking a look at the resting levels. There's no differences, in schema in these patients. So those two populations are pretty comparable in terms of their cardiovascular disease burden, I would say.
So related question, maybe I missed it. Are all these patients not on anti-inflammatories of any kind? No aspirin?
No, so these patients we control for we control for some. Well, it's not here in the slide, but definitely we control for antidepressants. We also control for statins and aspirin.
Okay.
Yeah.
So it wasn't a chronic aspirin regimen?
Well, most of these patients, they at least I would say about almost 90% they were on aspirin, and we control for that.
Yeah, but it's a challenge for you. If everybody's on it, you can't really control
Yeah,
for it.
yeah.
So it may be flattening your responses.
Well, yeah, that's definitely a possibility here. Statins and aspirin, that's the standard of care, for these people.
So I'll ask the same question as I asked the previous speaker. Did you have a look at neutrophil lymphocyte ratios?
We have that data, but I haven't looked at that data
Take
specifically.
a look. Could be helpful.
Okay.